good morning, good afternoon, or good evening, wherever you are. Thank you for carving time out of your busy schedules to join us today. I'm Dr. Srinitha Singanamala, and I'm joined by Dr. Ann Dorsey. Together, we are going to walk you through how to get the absolute most out of your partnership with BeamReaders from the moment you decide to refer a case all the way to the final report landing in your inbox. Our goal today is simple, to help you submit better cases so we can give you better reports. So we have split this webinar into two parts. I'll be covering the nuts and bolts of the submission process, including common pitfalls, best practices, and also workflow tips. And then Dr. Dorsey will bring the clinical perspective, including the real cases, real consequences, and what can actually make a submission truly shine. A quick introduction for those who don't know me yet. My name is Srinitha. I go by Sri sometimes. I completed my dental degree in India, practiced general dentistry for a few years before relocating to the United States. I've always been passionate about radiology, and I pursued my specialty training in oral and maxillofacial radiology at Texas A&M. And apart from that, I also hold a master's in public health from Nova Southeastern University, and I work with BeamReaders.
Hey y'all, my name's Anne. I'm an OMR and an ACBOMR diplomat working with BeamReaders. A bit of backstory about me. I didn't know I wanted to be a dentist. My mother was a teacher and she inspired me to go on that path. So I became a high school teacher, a chemistry teacher specifically, first in Phoenix and then in Yuma. And I'm happy to talk about Walter White and how realistic Breaking Bad is at any time. While working with my students, I was inspired by the impact that a local quality dentist and eventually oral and maxillofacial radiology care had on my students. After a lot of post-bac classes, I got my DDS and then my MS in OMR, and I feel really lucky to be here. So our roadmap today, we have 4 key objectives we want you to walk away with. First, we want to go through our traffic light protocol, which I'll elaborate about over the next few slides. It's a simple framework intended to help you determine whether you should send a case to an OMR for a read. It's very easy to remember and even easier to use. Second, we want to make sure that you know how to submit those cases effectively. We'll give you some really practical tips that'll save everyone time. Third, what information helps to create the most useful report, because like you know, not all clinical details are created equally. And fourth, which cases benefit the most from an OMR's interpretation. Spoiler alert, it's probably more than you think, but I promise we're not going to give you things that are at all self-serving or be every single little thing. So a quick interactive moment, using your reactions or by typing in the chat, how many of you currently have a systematic protocol for deciding when to refer a scan out? No judgment either way. We're here to make this easier for everyone. So for those of you who even have a systematic protocol, I want to make sure that I really emphasize something. In your protocol, you really need to have a step that is write a comprehensive documented report whenever you take an image, especially CBCT. This serves many purposes. It improves patient care. It is a documentation that you have reviewed the volume, and it reduces your liability. Would you ever do a filling without writing a note about it? Probably not. So you shouldn't take a scan without writing a comprehensive report. Some of you might not have the bandwidth to write one of these, and trust me, you're not alone. That's what we're here for. We've got your back. And for this reason alone, some practices choose to refer every scan to an OMR. So the traffic light protocol, this is designed to help you whether you have a system in place already or whether you need to create one from scratch. Stating the obvious, a traffic light is a tool created to help manage the flow of traffic with 3 color options: red, yellow, and green. And breaking that down in our terms, a case is defined as red light when you should always stop and refer, just like at a traffic light. These cases are determined to be the highest risk profile and would always benefit from the eyes of a radiologist. These cases usually require a ton of training for comprehensive interpretation. And for some of you, the risk of missing an incidental finding, which can be pretty high, there are incidental findings in a lot of volumes, is enough to send CBCT to an OMR. And we know that a lot of you are really highly trained in many aspects of dentistry, and your red light standard might be very high, and that's great, as long as you're documenting a report for that. So for a yellow light, again, just like a traffic light, it means approach with caution. You have the option to either proceed carefully through the intersection, meaning interpreting and writing a report on your own, or slow to a stop and refer to an OMR. This is where you consider your own training level, the specifics of the case, whether there might be something that an OMR could meaningfully contribute to the case, and sometimes what changes from a yellow light to a red light might depend on the day, such as the limitation of your valuable time. Or it might be a larger field of view that you're not used to looking at, or you truly might just want a second set of eyes. They're all great reasons for slowing to a stop instead of proceeding with the case. And when in doubt, again, know we have your back and we want to help you with these cases, and we'd love for you to send them our way. Lastly, a green light means that this is a case you always feel comfortable interpreting on your own. However, you have to remember that you must proceed with responsibility. Here are some examples you can see of the reasons that different practices have provided us of what a red light case is, what a yellow light case is, and what a green light case is. Again, these standards could be different for yours. These are just examples to keep in mind. For red light cases, I want to bring your attention to this last bullet, practitioner uncertainty. And I hope you can remember, and I'm telling you this now, it is okay to be uncertain. Recognizing uncertainty is not a bad thing, and we are here to help. The more I learn about CBCT and pathology and artifacts and airways and TMJ, the more I recognize that there is so much still to learn. I'm really lucky at BeamReaders, where if I have a question, I have 65 and up other radiologists that I can instant message that can give me some perspective. And even our founder, who has been practicing radiology for 40 years, frequently says during team meetings, I think I've seen it all until I open that next volume. Last thing I'll say for this slide, when a light is yellow, sometimes it's best to err on the side of referring. It's always better to have an expert confirm your impression than to miss something. And I know that coming from a radiologist that you may take that with a grain of salt, and of course that's something I would say, but I say it because it's true. And because if you decide a case is green, you really need to make sure you have the time, bandwidth, and training to complete it to the standard of care. I encourage y'all to download the traffic light protocol. It's super helpful. Also, it's free. Just download from this link here. And for the next portion of the webinar, I'd like to pass the baton back to Sri.
Thank you, Anne. That was great information on traffic light protocol. We're going to get into the practical, everyday stuff, what usually can go wrong with case submissions or case upload issues, and how we can fix them, what makes a good case submission, and best practices that can be followed. Think of it more like a behind the scenes kind of a tour of what happens on our end, so you can see where small changes on your side could make a huge difference in the quality of report, what we can send back. And I want to remind you here that you are the clinical experts with the patient in front of you, and we are the imaging experts with a trained eye on every slice of that volume. From the moment you take the scan to the moment the report comes back, every step here really matters. The quality of that final report is only as good as what goes in at the beginning. So we say at BeamReaders, great information in and great report out. Take a moment to look at this flow. Think about where in your own office the process might hit a speed bump. That awareness alone can prevent many of the issues we're about to discuss. Here is an image of how it appears on the BeamReaders portal first when you're trying to upload your scan. There is first name, last name, gender, and also race. Race here, we say it's optional, but we ask for race here as clinicians know that some conditions have higher incidence in specific races. So especially if your study purpose is a pathology, then it's highly recommended to include this information here. Secondly, regarding the study details, the first one would be the study purpose, followed by clinical notes, followed by private notes to the radiologist. And at the bottom, you have where you can upload your file, the CBCT DICOM file over here. And on this image, I want to show you that when you click this study purpose, you get all these different options here. It's really important in this step here to ensure that you are selecting the right study purpose for the scan. For example, a provider needs an airway evaluation, or a provider is suspecting a pathology, or maybe they need a general read. Keep in mind, we do go over the entire scan regardless of the study purpose, and we do provide a comprehensive report. However, selecting a correct study purpose really helps us radiologists to know what the provider is actually looking for. And so we can provide clearer, better reports, and of course, faster turnaround times. These are some of the most common submission issues we see. First one is incomplete uploads or missing files, followed by missing or mismatched patient details, poor image quality, missing prior records, and lastly, unclear urgency. Any of these can really delay your report, dilute our recommendations, or could even require us to come back to you with follow-up questions, which means more time being lost before you receive your report. The good news here is every single one of these issues, they're easily fixable with a few small changes. All right, so let's break them down. So first up, I have incomplete uploads. This is more common than you think. We have seen cases where a full week passes between file uploads for the same patient. That's a week of diagnostic limbo. The fix here is simple. Make sure that your file is fully uploaded before closing the window. Check your file sizes and know what a standard report size should be for your practice. And most importantly, make sure your office staff is trained on this, because often it's not the doctor who's uploading the files. Your team needs to know what a successful upload looks like. Next is missing or mismatched patient details. This one sounds minor, but it can really create big problems. So when the patient's name on the case submission form, if it does not match the name on the CPCT data, the volume, we have to stop and we have to verify. It's the same with date of birth. All the data has to match with the volume and the case submission form. We need to be 100% certain that we are reading the right scan for the right patient. So best practice here would be, before you hit that submit button, take 30 seconds to confirm the name, date of birth, study date, everything match between your case submission form and the actual CBCT scan, the DICOM data. So here I have example image. Depending on the software that you have, when you click on the eye over here, which I'm showing with a yellow circle, please make sure this information matches with your case submission form. Next is missing prior patient medical history. This is a big one and very common. Context here is everything in radiology. So here is an image of rad chats that we at BeamReaders use to communicate directly between radiologists and referring doctors. I have an example of a rad chat here where I message to the provider's office using this feature on the BeamReader portal, asking if the patient had a history of an implanted VP shunt, which is a ventriculoperitoneal shunt, and the office came back to us after a week and they said, yes, in fact, the patient did have an implanted shunt. Although this communication did not delay completing the report for this case, but this type of delayed communication can result in delays in reports due to the office not providing useful prior medical history. Again, I would like to emphasize here is that if a patient had a biopsy or they have been undergoing treatment for a known condition, that changes how we interpret what we see on the current scan. Think of it this way, if you went to a new doctor and they had zero medical history, they would have to start from scratch again. It's the same thing for us. Best practice here would be provide background information and context at the time of submission. Attach your prior reports, relevant clinical notes, or even just a sentence or two about what's been going on. It all really helps. So for those of you who are not familiar with RadChat, basically it is a direct form of communication between you, the provider, and your radiologist, which is built into the patient's profile. You can send this type of message to your radiologist directly. Scroll down past the radiology report in order to find it on the radiology page. And on the radiology page of patient's profile, you just select RadChat. Once you're there, you can compose your message and send your message to your radiologist. And this message is completely private and it's not visible to the patient. This is a great way to communicate pertinent clinical information and verify report completion timeline. Let's go over some patient instructions here that needs to be given, which are crucial before taking a scan. So first, instruct the patient to stay completely still during the scan, because interestingly, the number one scan killer is motion, and we do not want artifacts from motion, as these can render the scan almost impossible to read and may require a retake in such cases. And secondly, ask the patient to remove everything from their mouth, like gum, candy, retainers, partials, or any dental appliance, because any object could potentially create artifacts again in the area of interest, making the interpretation difficult. You may ask the patient to remove glasses, earrings, necklace, hearing aids, or any metal object near the head and neck region, because again, such objects can create serious artifacts in the scan. You may ask the patient to stand up straight or sit up straight, hold as still as possible. I want to emphasize here that being still is really important during the CT scans, as they are generally longer than your regular traditional PAs and bite wings. So the patient needs to remain still for 20 to 40 seconds throughout the scan to avoid motion artifacts or any artifacts. And lastly, ensure that your patient's tongue is positioned on the roof of the mouth. Especially, this is important if you are requesting an airway evaluation. It's important for the patient to stay completely still during the scan. If not, here is a classic example of motion artifact, which can lead to poor image quality. You can look at the image on the left, these double cortices in the mandible and to air the C-spine. And on the right, you're able to see double cortices. If you get a scan like this, it's worth considering a retake rather than submitting it. A clean scan saves time. It's important to remove everything from the patient's mouth before scan. So here I have an example where there is a comestible in the patient's mouth. And yes, that is exactly what you think it is. The patient was chewing something during the scan. All right. So now let's go over two example cases. So here is one of my very fascinating cases. And so I found two interesting incidental findings here. One is the arcuate foramen on the right, also known as ponticulus posticus on C1, pretty common here, as you can see here. On the left, along with that arcuate foramen, I found partially ossified skull-base ligament. So here is a volume rendering image showing arcuate foramen on the right side of the patient. So this basically represents an ossified bony bridge on the posterior arch of the C1. On CBCT, they may appear as complete partial bony ring. This here is a completely formed bony ring. Generally, even though this can be considered as a normal anatomic variant. It can also be reason for cervical symptoms. This is an anatomic variation which is formed by ossification of posterior atlanto-occipital ligament, and it contains really vital structures, vertebral artery and suboccipital nerve, and also has been reported as a possible cause of posterior circulation ischemia and also sometimes cervicogenic headaches. And here on the left side of the patient on this image, we can see there is a partially ossified skull-base ligament. Here, can you see this ossified structure jutting out, which is shown using yellow arrow, and the blue arrow is indicating the arcuate foramen, only partially seen on the right side. Definitely this would be considered as a classic example of a red light case because it's a large field of view, first of all, and it's symptomatic. The patient had definitely symptoms as reported by the office. When I reached out, they did say that the patient had neck stiffness, and it was confirmed by the provider's office. Secondly, this is a red light case because the patient was symptomatic and there was unclear etiology, and there was a known or suspected pathosis along with practitioner uncertainty. In the second example case here, where the provider they requested a regular general read, and we did not have any clinical notes or any medical history of the patient. I found some very interesting findings for this patient. In the sinonasal region, extensive, massive destructive changes, including septal perforation, turbinate loss, absent ethmoid sinus floor, discontinuous maxillary sinus walls, and collapsed nasal alley. The differential was given as granulomatosis with polyangiitis, formerly called as Wegener's granulomatosis, and it was confirmed with pathology as well. So this condition is a rare autoimmune small vessel vasculitis that can cause serious inflammation, affecting multiple organs, especially the sinuses, lungs, and also the kidneys, leading to tissue destruction and even organ failure if untreated. So here I have enlarged the image so that you can see the massive destructive changes here. This is definitely a classic example of a red light referral case because of the large field of view scan. And typically all large field of view cases, they are considered to be red light cases, needing a referral to a radiologist for interpretation. And particularly this case needed an expedited ENT referral because they had massive destructive findings. And again, here I want to emphasize that any case, if you're not comfortable to read, look suspicious, or you're just wanting a second opinion, they can be treated as a red light case, and that may be sent to a radiologist for interpretation. Let's talk about how you as a provider can help a radiologist better help you. The quality of a radiology report is directly related to the quality of information we receive from you. So basically, there are three simple ways to help us provide most clinically useful interpretation. First one is providing a clinical context. Secondly, asking specific questions. Thirdly, including supporting information when available. So first, providing clinical context. Even a few details about symptoms, duration, progression, restorative, or any kind of medical history, any prior treatment even attempted, can really improve the specificity of our report. And second, please share with us what is the reason for imaging, whether you're evaluating an implant site, tracking lesion progression, identifying a source of pain, or just ruling out any pathology. Specific questions help us focus our interpretation on what really matters most to the patient care. And finally, include your supporting information whenever it is available. Prior imaging, any kind of clinical photographs, pathology, results, specialist notes, and relevant surgical history. All of these help us build a complete clinical picture instead of working from a single snapshot. Ultimately, I want to emphasize that clinical context transforms imaging into a patient-centered interpretation. Next, Anne will take you through part 2 of this webinar.
Thanks for taking us through that first part of the webinar, the common case submission issues and what makes a good submission and best practices. In the next portion of the webinar, I will go through clinical perspective and why submission quality matters. Just a quick reminder, and Shri talked about hammer this home pretty well, but we always do a comprehensive, thorough, and documented report no matter what you provide us. So if it is your practice to send minimal information in the report, you'll get back a thorough report. That's our job, that's standard of care, and it's documentation. And honestly, love writing reports. I know that's not everyone, but I love it. I just wanted to offer some patterns I've noticed, and Sri talked about these a little bit, and I want to offer you some solutions. The first one is pain or a symptom without supporting information. I will say pain, usually that's a pretty good, if you're going to write one word, that's a good word because I will look for any possible source of pain and I will tell you about it. But it might be a little too broad for you. So if you could provide any focus, such as duration, intensity, any change of status, any recent treatment, so helpful. A second common problem is no site listed. And so often people will ask for implant evaluations or something similar, and they will not provide a site, and there'll be multiple odontologist sites, but they're only interested in one. And so if you do not list a site, we don't provide a focused implant report. And so you might not get all the information you need. And so that's just something that's helpful for us if you provide a little additional information. Third would be there's no indication of urgency. A lot of the cases we receive, we are given 3 to 5 business days to respond to that case to submit a report back. But some cases you need a faster turnaround time than that. BeamReaders has multiple ways to rush a case to your OMR, and we can get a report back to you same day, within a few hours, or within 1 hour. And those are all things that we can help you with if you want to provide care to your patient faster. So we're really able to help you triage that case if you would like. And then third, and Tree hammered this home really well, poor scan quality. Again, we can only work with what we're given. If an image is noisy, if it's limited in the field of view, if it doesn't include the area of interest, which happens, or it's compromised, then our ability to give you a good answer is limited. So in summary, why does catching these problems and addressing them in your referral matter? Follow-up questions we need to ask when we need more information. That time spent for us and for you disappears. General reports that may not be as clinically useful become focused and become clinically useful. And then if you have an urgent case, that case is given to you and provided to you with enough time. And as a result, all of those missed opportunities from a little bit of lack of communication can become a more fruitful clinical relationship. So I have an example here of a referral, which is fine. We get these kind of referrals all the time. And although it's sparse, I really don't mind reaching out and asking for specifics. So for this case, and I'll show you some images in a bit, this provider usually does provide a focused area, an area of interest. And so I immediately reached out to them via rad chats. But while I was waiting, I reviewed their report and I was like, okay, well, what could they be concerned about? And so during my normal thorough evaluation, I was like, okay, this practice normally wants an airway evaluation. And so I was looking at the patient airway. You can see here, their tongue isn't ideally placed. They've kind of placed their tongue tip on the roof of their mouth. And so their tongue is a bit posteriorly and inferiorly positioned within the airway. A quick fix for this, instead of telling your patient to put their tongue on the roof of their mouth, you can just have them swallow. And then that'll put their tongue in the natural position. If this was an airway evaluation, I would need to alert the practice that this isn't an ideal placement, but you can see that the airway measurements look okay. according to our standards. So maybe they want an evaluation of the nasal cavity, which some practices want. You can see here that we do have a little bit of not hyperplasia, but a little bit of mucosal thickening of the nasal cavity, which could merit a referral to an ENT or allergist if the patient is reporting symptoms. Sometimes this practice likes a TMJ evaluation. And so I looked at the TMJ while I was waiting for them to get back to me. And there is some adaptive remodeling, which are just kind of like physiologic changes to the condyle over time. And there are some signs of internal derangement here. So maybe they were interested in the TMJ evaluation. A few days later, the practice got back to me. And for the first time in our 3-year working relationship, they wanted an implant evaluation, which is a totally different focus of the report. So specifically for site number 3. An implant evaluation, we include this specific image for you with customization possible, of course, but we don't provide this image if you don't ask for an implant evaluation. Often scans have multiple odontolar sites, and so we'll just describe the general quality of the bone, but often practices like to use this kind of image as an supportive information for their treatment planning. And so they wouldn't have gotten this if they hadn't asked for it. Our original referral here on the side, please evaluate, which lacks a lot of that necessary information. And then after a bit of back and forth, you can see we have a much more detailed referral. And this allows me to provide the referring doctor what they need for me to be a helpful member of the team. And I really love being able to provide a report that's useful to you, to a provider. And even though they were interested in just the implant site, I was able to let them know that they should take a look at the TMJ. They might need to send this patient to their primary care provider or to an ENT or allergist. And they did. And the patient actually now has a much higher quality of life. So, benefits of a thorough report. So that's just an example of a submission that needed a little work. And then I wanted to give you a little bit of clinical perspective because many of you provide very strong submissions. And I wanted to show you 2 examples of that. Again, for those reports, we're looking for that clinical relevant information. We're looking for those symptoms and urgency. And we also, if you have specific treatment protocols that you like to follow, we'd love to hear about those. If I get these things in my referrals, then I feel like I'm much better able to be a better healthcare provider and partner. So here's the first case. And this is an example sent from one of my regular practices. And it's a large field of view, and they're very interested in an airway evaluation. They wanted the airway evaluation because the patient was reporting airway concerns. So if you think this would be a red light case, you can react. You can type in the chat. And then if you think it's a different case, the yellow light or green light, please, if you could include your reasoning, that would be great for us. So the practice for them, this was a red light case. It was a large field of view. These are their standards that we've adapted to this list. They were symptomatic with an unclear etiology, and the practitioner wasn't certain. These are their red light qualifiers. Your practice red light qualifiers might be different, and that's fine. Just make sure that you're consistent so you can have those consistent conditions for your own practice. And so this practice provided all the necessary information, the clinical relevance, the urgency, their treatment decision pathway. And when I was beginning my systematic review, I found a really interesting incidental finding. So these are axial slices. You can see these yellow arrows here indicating a linear hypodensity that extends from the soft tissue buccal to the maxillary sinuses, which you can see here, to the region of the parotid gland, tracing the parotid duct. And I'm zooming in a bit more and then a bit more so that you can see this a bit more easily. So you can see this line here tracing that parotid duct. And the most common thing that this could be is just introduced ductal emphysema, which is something that we're very familiar with in dentistry, as air can be introduced into the soft tissue by accident in nearly every operatory. I remember in dental school that happening pretty frequently. However, this air could also represent infection or a pneumoparotid. Regardless of what this is a significant finding because this is a potential pathway for retrograde introduction of microbes. The practice didn't know about this, and the patient was not yet symptomatic. And so this kind of early finding can be really helpful. In fact, it changed the course of this patient's treatment. This CBCT was captured on the patient's initial appointment, and they were able to shift the patient's treatment care plan to one that followed a more urgent incidental finding. They were able to address this. They were able to manage symptoms early because the patient did become symptomatic, and they were able to prevent future pain and inflammation just with this incidental finding. And as a result of that management, the patient is now addressing their reason for visiting this practice, which is airway evaluation, as we have said from the start. You can see here they do have a radiologically limited airway. And again, CBCT is not a definitive airway diagnostic, but it is a diagnostic tool. And so you can see here, we have restriction in the airway, and then even their nasal cavity demonstrates mucosal thickening that could narrow the airway. And so they've been referred to an ENT and an allergist and are managing that now too. Our second case, and this is my last case, this is a large field of view for a patient with unclear TMJ and related pain with recent onset symptoms such as pain, crepitus, joint popping, additional pain referring to the ear, tinnitus, and vertigo. And so I don't know if in the pan, if you can see this here, but this is definitely something that when I was looking and they had sent a reconstructed pan, I noticed this and I was like, okay, they are having, issues with this area. This might be it. But we always do a systematic review. And then after that, focusing on this area. This practice, this was a red light case. It was a large field of view, symptomatic, unclear etiology of a suspected pathosis, and the practitioner was uncertain and also just wanted a radiologist eyes on it. And so I'll zoom in this image in a bit, but I just wanted to demonstrate their referral as an example of a model submission. They had all the details, including that they wanted this to be an expedited read, and that's always really helpful. And then actually this practitioner, they reached out to me. They just called me on my cell phone. They wanted me to know, hey, we want this before they leave the chair. We want to make sure that we take care of this. And so I'm zooming in here a little bit and then a bit more, just trying to give you the focus and perspective in case you're not used to looking at those coronal slices through a CBCT. And you can see these yellow arrows are indicating a really ill-defined hypodense lesion that's affecting a large portion of the temporal bone. For a finding that looks like this, there are two things we're really concerned about, and that's either inflammation or malignancy. This patient, and as the provider recognized, really needs an expedited referral to an ENT for additional advanced imaging such as MRI or MDCT and additional evaluation, especially because the patient was in pain and with recent onset of pain, and they were demonstrating other very significant symptoms. And so to bring this all together, the practice recognized the urgent nature of this red light case. They requested a same-day read. They needed that for fast treatment. And because I've been working with this practice for a while, and this is something that sometimes your OMR can help you with, we've been able to make a network connection between me, this practice, and ENTs who have access to additional advanced imaging and provide expedited care. Because of this, we were able to determine that this was indeed inflammation. Honestly, thank goodness. Not that that's a good thing, but it's much easier to manage, especially to this scale. And because of this, the patient received appropriate care, and we were able to get the patient out of pain. I'm always so grateful to be able to help with that kind of service. I followed up with this practice 2 weeks ago about this patient just to continue with standard of care. And the patient is so happy. And they told the referring provider that they'd never felt more taken care of. And that's just exactly what we're going for. That's what clinician radiologist collaboration looks like at its best. And it's the standard that we're all working toward together. I know that sometimes OMRs can feel a bit out of sight, out of mind for referring doctors. I know y'all are so busy with your practices, and sometimes it's easier to keep up with those other healthcare providers and specialties with like a study club or a meeting for lunch or something like that. But I hope that you can take away from this presentation that we are members of your healthcare and your treatment care team, and we are ready and we're willing to help. The final takeaway. So better input equals better output every time. The quality of the information that you send us determines the quality of the report that you receive. And all we want is to be the best patient care partners that we can be. We want every CBCT captured to have a systematic and documented report. Whether we do that or not, it should be done. Not whether we do that or not, but whether we do that or you do that or not. It needs to be done. We want you to figure out a protocol for when you can complete those reports. So a green light, yellow light when you're deciding who to do it yourself or to send it on, and red light protocol. We're also very happy to help you set up those parameters. We ask that all referrals sent include the necessary diagnostic information. These aren't bureaucratic requirements. That information is really helpful to us, and it helps our interpretation and sharpens our reports. And finally, we want you to think of radiology as part of your collaborative care team. We're not just a report generation service, although I do like writing reports, don't get me wrong, but we are part of your patient's care team. And when we have what we need, we can be a much more valuable partner. And again, the goal is establishing a predictable protocol that allows you to know and send cases with necessary information to enhance patient care.